Ryan Stanton here with ACEP Frontline here at Leadership and Advocacy Conference. And we are talking today with Dr. Aaron Kuzel, or I call him Kuzi. He is a fellow Kentuckian from Louisville, and that is the way we say it, which is, it's our northern version of Kentucky cities. But we'll let him in. We appreciate it.
Appreciate it.
So Kuzi's one of my good buddies that we've done a lot of advocacy together. I mean, last year you probably saw us lime scootering around the Capitol area, having a great time. I look forward to doing that again here tomorrow. But you are here today talking about some of the rural transformation, the Triple B, and the legislation and what that's going to mean for some of the rural access and care. So first and foremost, since it's your first time with us on the podcast, is give us a little background on yourself.
Well, thank you for having me, Ryan. Out of the four Kentuckians here, it's not good to have two of us together. We're going to have a cabinet meeting to, if one of us goes and
there's
falls.
There's some special permission to have two of us in one spot.
Yeah, we have to be around serving bourbon for the most part. But nice to meet you, or nice to be here, and nice to meet you all out there in podcast land. My name is Aaron Kuzel. I'm an emergency physician out at University of Louisville. And I'm also a director of observation medicine out there, and work in EMS as a EMS medical director for two wonderful rural agencies, Spencer County and Bullitt County EMS.
That's the interesting thing is approximately 10 to 20% of all the double-boarded EMS physicians in Kentucky are in this room right this very moment.
Yes, as a matter of fact, they are. So it's great to have, and always a pleasure to be with you and my fellow 20%er.
All right, so let's talk about that a little bit. You do a lot of stuff through U of L, and of course we've done a lot of the legislative stuff this year with regard to some of the legislation that came through, some of the rural aspects of things. We actually put in an application for the Rural Transformation Project. So kind of dive in just a little bit of a intro, aperitif of what you talked about today.
Sure. Well, as Ryan mentioned, we did have a large legal, or I guess political battle in Kentucky, where we offered the bill HB 107, which was, as you know, to get a physician every ED, and push back against SB 12, which was to make level 4 trauma centers in rural areas, but only staffed with a nurse practitioner or PA. Now, while we respect our PA and nurse practitioner colleagues, we have to be careful that they're not being put into positions that are going to put them in harm, and also with patients in harm. And that's why it was of our advocacy. But because of this, it's allowed us to get a position to talk about rural healthcare in Kentucky, and it's been a way to get a position for us to negotiate with the legislature to make EMS, trauma care, and emergency medicine part of that conversation. And so what I talked about today was that Rural Transformation Fund. That's the $50 billion fund that's been part of the One Big Beautiful Bill. Was kind of a olive branch to get certain senators to vote who were worried about the 20% cuts in Medicaid. Mm-hmm. And so they created this $50 billion to hopefully transform rural healthcare. Obviously, rural healthcare, every rural hospital is saying that they're about to close, or they're saying that they're in financial trouble. Not all, but most. And so this was sent out to the states across all state platforms. Usually comes out to about 1.2 to 1.6 billion across the states over a 5-year period to kind of transform what rural healthcare looks like and what it'll be shaped up to be.
All right, so let's talk about that a little bit, because what ended up with the legislation in Kentucky. So we talked about Senate Bill 12, we talked about House Bill 107. What ended up was a joint resolution that charged U of L, University of Kentucky, and Eastern Kentucky University. U of L and UK both have medical schools. Eastern Kentucky is going to have an osteopathic school very soon, with rural access, recruitment of physicians into the Commonwealth, and then kind of making sure to sustain and protect our rural access. So kind of in your experience and kind of going through this, can you give an example of how the rural transformation, that money is going to impact, rural Kentucky hospitals? Because it's something we can translate to all 50 states.
Yeah, and there's some great states that are doing it a really great way and have already kind of submitted proposals. I do laugh at Kentucky. It's a very Kentucky thing to say. Who's going to fix rural healthcare? Lexington and Louisville, mm-hmm. or in Richmond, by a smaller extent. So I always laugh at that fact that when we think about rural hospitals, let's go to Louisville and to Lexington. But joking aside, what we're looking at is different priorities and addressing those priorities of how do we make it sustainable. One of the biggest challenges in Kentucky is a paramedic shortage, and that paramedic shortage is affecting many of the rural EMS agencies. My rural EMS agency, Spencer County, we have 192 square miles, 19,000 population, and we do that with 2 ambulances. So about the half square mileage of Louisville, and we do it with 2 ambulances. You look at 25 to 30 ambulances in Louisville, you do it with 2 in Spencer County. So how do we keep paramedics? I can't keep paramedics. I can't keep up with the cost to afford a paramedic when I'm competing with Jefferson County with a paramedic that is going to have either hazard pay or work a really great schedule of 72-24 or 24-72, I should say. So that's one of the things we're addressing. There's a great program out in Hopkinsville that is accredited as a training center for paramedics through community college accreditation, and they're starting to look at different agencies to host their programs through online, and then using NREMT instructors like paramedics to do the simulation, and then they do their clinicals associated with the hospitals that have already been pre-established with those EMS agencies. So how do we fund that? But also looking at the money for the Rural Transformation Fund and putting it into almost like a grant so that we can pay paramedics while they're doing their clinical time, so that their clinical time is like working. So they're making a salary, or even if it's not going directly from a tax perspective to that paramedic, it's going to the agency who can put that as part of their salary. There's some tax challenges we'd have to look at, but it can be like a grant program working that out with the state legislature. Other things we're looking at, what I like about what Indiana does is they do it by region. So they're asking the different regions in Indiana, and this is through efforts in Indiana, ACEP, as well as other partnerships with Indiana. They're asking the regions what they need, and those regions are providing proposals. And if those regions are successful, they'll fund the rest of that program for the next 5 years and possibly translate that to other parts of the state. In Kentucky, I imagine it would be very similar. We're hoping to probably cut it in half. Due west is going to be around Louisville. Due east is going to be Richmond, and then Kentucky's going to get UK is going to get central. I imagine that's how it's going to shake out. I don't know for sure, but I imagine that's how it goes. As much of the state is drawn in by that line between UK and U of L. But we're looking at improving dental care, so not sending patients from hospitals, teaching emergency physicians and physicians working in emergency departments to do the I&D, to do the inferior alveolar block, give them 12 hours so that they can go to an outpatient dentist rather than being transferred all the way to Louisville just to be seen by a dentist or an oral maxillofacial surgeon. Other things we're looking at is like a operations center. So looking at how do we track every single bed? How do we track every ambulance that's going? Because the idea is we only have 2 ambulances in the county. We don't want to send those 2 ambulances that are supposed to be 911 and have them take patients from Shelbyville Hospital or Bullitt County Hospital and send it to Louisville, because that takes you, for Spencer County, that's a 2.5 hour round trip for 1 ambulance, and now you're down to 1 ambulance in the whole county. So finding ways to keep 911 ambulances, figuring out how to put beds and get the patients where they need with the appropriate amount of care. And the last thing we're looking is technical, so being more of telehealth consultation. Now, Dr. McGowan in our discussion brought up that some places don't have service, and that's still an issue in Kentucky, more so in Oregon and out west, but we still don't have 5G coverage. So we have to figure out how we're going to be able to deliver this. What I think would be great, and I think this is something that could be adopted everywhere, is you can leverage your consultants you have at these large metropolitan institutions, give them a salary for the time, get them on the telehealth so we can keep patients like the subdural, and looking at the trials that say we can keep subdurals into those hospitals, recheck it at 4 hours, and then decide whether or not they need to be transferred, willing on transport and if availability, weather coming in, et cetera. But I think that's where we can transform rural EMS and rural healthcare. Instead of sending these patients out of their communities and then they get stuck in metropolitan, we can't send them out because it's 3 hours to drive home, or they have to have a family member come and pick them up. We keep them at home. We do their management there. They can see ENT as long as their airway is okay. We can get them to follow up in 2 weeks when they have the time, can arrange the transport, rather than just trying to take them out of their community and trying to work with social work and other tools and other resources to get them back home.
And the stability of a lot of these rural hospitals has to do with being able to keep people in their communities.
Yes.
We know they're going to like it better. They're going to like staying there better. They can still see their family. I still remember working at the University of Kentucky. Folks would come in, they get transferred up. Family couldn't come because they either didn't have a car or the money to buy the gas for the car to make that entire trip. For us, it was split halfway because we had University of Kentucky with level 1, then Tennessee had Johnson City and Kingsport that had level ones, and then Knoxville, and everything that got split halfway in between. And working at a small ED moonlighting called Fort Logan, and it was in Boyle County, and they had 2 ambulances at the time. And if one of them was on the road to UK, they would not take the other one out of the county. And so even then, relatively minor things had to be flown. So that $25,000 bill for somebody who could have, gone via ground ambulance would have been much more cost effective. So it really is about keeping people in their own communities, bolstering up these hospitals and allowing them to have the resources. Because I feel like so many transfers now are a what if.
Yes.
What if this happens?
What if the abscess grows? What if their airway gets cut off and they're sitting there talking to you and having their lunch? They're pretty much eating their Carl's Jr. and Hardee's right there in front of you. I think their airway is going to be just fine for 24 hours at the least. Not always, but for the most part.
You can't predict everything. But even for us, when we don't have interventional radiology at the hospital, it's like, well, what if that GI bleed needs interventional radiology? What if? So let's transfer them. And it's that idea of saying, what are the resources we can provide to keep the people closer to home? Because actually, rural and small town hospital care is more effective, more cost effective, more efficient, and gets people home faster than trying to get up to the larger type systems, UK, U of L, or wherever it may be.
Yeah, I couldn't agree more. We've all seen, living in Fisherville and driving to Taylorsville and Spencer County, you come up to the pump and you see someone put in 285 or now 430, and it's just 1 gallon, which is probably just to get home, just to get to work. So that is a real thing that we don't consider as physicians that our patients are living with. And I talked to a colleague, Dr. Garant, who was very helpful with getting us to stop SB 12 in the House. He has a Democratic group out in Danville, and he talks about the same thing. When you look at what he's done with his Democratic groups in those critical access level 4 hospitals out there outside of Danville, and his Democratic group in Danville proper for their hospitals, our F. McDowell, those hospitals are keeping patients more, they're transferring less, and they're getting better patient satisfaction, and patients are becoming loyal because people are smart. If they are getting bad care, and they are getting or subservient care, and they know that they can drive an hour and a half to another large metropolitan suburban hospital, they're going to make the drive, even if it means they're going to have a cardiac event or they're going to have a stroke that doesn't get within the window, because people are smart. They know what kind of care they're going to get, and they evaluate it. It's a free market economy. And
that's actually the group you're talking about, that Democratic group. Eric is a good friend that I worked with him as a hospitalist. As a moonlighting back right after he came out of U of L, and they have that very internal. Even Fort Logan, which is within that same system, the hospital I referenced before, a lot of those don't go to the larger city. They get transferred over to Ephraim, and they keep a lot of things internal. That's a very forward-thinking hospital system. That's one of my favorite hospitals I ever worked with Ephraim and Fort Logan, and that is part of that solution. They're only 30, 45 minutes outside of Lexington, but it's one of those things where that's the kind of the replication we need to see, and why physician leadership and physician investment in the community is so important, because then you do take pride in keeping those patients and providing the services necessary to keep people nearby. And every legislator is going to tell you, or at least what we heard in our discussion in Kentucky is, doctors are too expensive and we're going to bankrupt the system. But you look at the Indiana, South Carolina, and Virginia, every time that when they did their legislation to make it that every physician in every ED, as far as we know right now, no hospitals closed because of that. Yeah. And so if we invest in the community, we invest in physicians going out there, whether that is a stipend for Democratic groups to help support and help build other Democratic groups or other physician groups in those areas, we know that patients are going to get better care, absolutely, but it's probably going to be cheaper in the long run for hospitals, because now you're keeping more patients, and as long as you're not going to like a rural emergency hospital, which you're just trying to keep access open, and you're still trying to fill the beds with inpatients, you're going to do that with emergency physicians, because they're going to either do the procedure that otherwise you couldn't get without going to one of those suburban or metropolitan hospitals, and you're going to keep patients in your hospital. And that's one of the things that we're seeing is in these other states, the calculations for the physician being in the ED really in the end ends up almost being a rounding error in terms of the difference. And especially as some of these, the physician payments have been relatively stagnant, going down and compared to inflation. Others are going up in terms of their cost and things. it really is that importance of having that that MD-DO based specialization or education to be, because you don't. One thing people say is that how do we get more docs out into rural environments? Well, rural environments takes like some of our smartest physicians,
Yes.
because you're doing everything.
Yes.
You are the doctor. I remember being at Fort Logan. I was the only doctor in that hospital for like an entire weekend. And so anything that happened was my responsibility. And understanding that you're the only doctor in that facility. Or when I was in the inner city hospital, and it was 3 hospitals inside one hospital because it had a vent unit and a long-term care facility, and you're still the only doctor that's credentialed in all 3. And so everything is your responsibility. And what we've found, just talking to the nurse practitioners and PAs, which again I completely agree, and an integral part of the team, is that they don't necessarily want to practice alone and independently in emergency medicine. It's having that team that is there, and then taking full advantage of that team to provide the best quality care and keeping patients in those communities as best we can. So that's actually where we're going now with Kentucky, is with that joint resolution, is diving into that and kind of seeing where the next steps are going to be in recruiting more physicians into Kentucky. The purpose of that osteopathic medical school in Richmond is going to be more geared towards rural care, which is exactly the school I went to. East Tennessee State was actually designed to provide primary care for Appalachia. And,
Same
that's
as mine, as Lincoln Memorial in
yes,
Tennessee.
exactly. So Lincoln Memorial, just across in Harrogate.
Yep.
You're the Harrogate campus, right? And then because they've got Knoxville and now getting Tampa involved.
Fine dining include Hardee's, Carl's Jr.'s, and Gondor, which is great.
There was
the Gondolia.
Yeah, the Gondolier.
Yeah.
It's very French. And then the one steakhouse in Middlesboro.
Yes.
Yeah, it's fantastic. I love going there and hanging out. It is a medical school. They actually have a fantastic Abraham Lincoln exam.
Museum.
Museum.
Yeah.
And they've got part of the stuff from his autopsy and
Yes.
things like that. So it's actually a very neat. My daughter was actually hooked on Abraham Lincoln history when we were driving
that's a
back
great
and
museum
forth
to go
between
to.
my family in East Tennessee and then back up in Lexington. So we'd always go right through there in Middlesboro. It used to be a Western steer that was the 50% mark between the two distances there. Now it's a Mexican restaurant. All right. So any closing thoughts on your session that you had today, since we've completely gone off the rails in our conversation? That's what Aaron and I do on the regular. Any closing
I think we hit
thoughts?
the main spots. I don't think we went off the rails. We had guardrails. We hit them, but I think we stayed within the lane.
Yeah, until the last little bit when we just went off
Yeah.
the side of the hill. So any closing thoughts as you wrap up, any messaging from the session today, because we had 400 plus people in there, but listening here is going to be 20, 30 times that of that message from that discussion.
I maybe 2 things. The first thing I want to bring up is talk to the residents and the residents who are listening to this podcast and hearing from attendings. I think as someone who practiced in a level 1 trauma center primarily, I love the opportunity that I get to moonlight at U of L South, which is our critical access designated rural hospital in Bullitt County. It just, as you said, like Fort Logan, you have maybe a nurse practitioner running the ICU at night, maybe sometimes you don't. I think now, when we first started, it wasn't the case. Now it's a little bit more regular, but responding to codes on the floor, knowing how to manage that, but also protect your ED, and it's a busy ED. So it's not one. It's probably one of the second highest volume in our system now, next to the metropolitan ones. But the lessons you'll learn when you don't have that resource, doing that now in training or finding a training program that allows you to do that while you're in training and having that supervision will make you a stronger resident over time, because you'll be able to handle. And if you make any part of your practice in a rural critical access hospital or just a rural hospital in general, I think it'll make you a stronger emergency physician. And I think if you eventually go to academics or go to suburban, you'll be light years, I think, ahead of your colleagues. Not to say that there's nothing wrong with urban training. It's just the things that you have to MacGyver and consider austere environment, if you would. The things that you had to figure out, how to make a transfer work. I mean, one of the most impactful things I had was a medical student in Beckley, ARH, West Virginia, and trying to find a patient when Wake Forest, UVA, Charleston, UK were all on diversion, and this patient was circling the drain, trying to come up with things of how to transfer a sick patient. This is before COVID, before crowding, everything. How to get that patient to level of care they need. I mean, we got a helicopter team to put in a critical care transport truck with an EMR driver to get this patient to Charleston once we got that. So coming up with those ideas, you're not going to learn that in an academic setting. So that, and second, we're going to really need to come up with major solutions for rural hospitals. I think there is an expectation we're going to lose most of these rural hospitals with a 20% Medicaid cut. Because if you look at this and you look at the map of every state, every one of them is in danger. Every rural hospital, in the most cases, is in danger. So if we don't, I don't know if $50 billion is going to do it. It may. I think it's a good potential Band-Aid.
Band-Aid for the
but
moment.
It's not going to fix the long-term solution. And so I would empower you in the metropolitan, suburban, and academic centers to really focus on your rural hospitals and be kind to those docs because they're working with challenges that we don't even see. But also, how do we help them? How can we bring our resources to them? Because otherwise, what's going to happen is those are going to close, and those patients are going to come. They're not going to not receive care. They're going to come. They're going to come to your ED. They're going to sit in the waiting room for 9 hours, and you're going to be yelled at about metrics because now the waiting room times are going up. Your boarding crisis is going to double because now we don't have those places to offload those patients. So we have to come up with solutions and work with our rural colleagues.
All right, talking with Dr. Aaron Kuzel, or Kuzi, and if you, we've got him here on the video for the video podcast, but this is actually the only time I think I've ever seen him in a suit, not in a vest.
Yes.
That is his MO, his typical attire when he's there. Maybe sometime we'll talk about your adventures with observation unit creation.
Absolutely.
And once you're kind of over the PTSD of all that cranking up.
Yeah, let me turn off my Papa Roach and stop pressing with my scars here.
Yeah. All right, how can folks get in touch with you if they have any questions, want to dig in a little bit deeper?
Yeah, love to talk about any topics, whether it's observation, EMS, and of course this topic.
And
you
Cuban
can reach
food.
me, and Cuban food. With a fence to Florida, we do it better in Kentucky. Second largest Cuban population in the country. We do it better. But you can reach me by email at Aaron, aaron.kuzel@louisville.edu.
The Aaron it is. All right, and as for me, you can contact me, rstan@acep.org, rstan@acep.org. Make sure that you're subscribed to the podcast on whatever your favorite player is, 5 stars, and then send us some feedback. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all
Yeah.
alone. Da, da, da.